Hello, my name is Dr. Allison Hotujec, and I'm a third-year resident in the University of Wisconsin Family Medicine Residency Program in Madison, Wisconsin. Today we are going to be discussing the use of arterial blood gases in the assessment of acid-base status. In the ICU setting, an arterial blood gas is an essential tool that allows us to better understand a complicated patient's underlying metabolic and respiratory condition. An ABG gives us information about a patient's level of oxygenation. An ABG also tells us about the patient's acid-base status. The information from an ABG can then be used to determine if the patient has a respiratory or metabolic acidosis or alkalosis. Family physicians must therefore be comfortable interpreting arterial blood gases. Today's podcast is going to specifically focus on the interpretation of ABGs in the assessment of a patient's acid-base status. First, everyone must be familiar with the lab values that are reported when you order an ABG. The first is the patient's pH. Next is the PaCO2, which is the partial pressure of carbon dioxide in arterial blood. The PaO2 is the partial pressure of arterial oxygen. While we won't be discussing it in detail today, this value can be used to assess for ventilation and perfusion abnormalities and other problems with oxygenation. Next is the bicarbonate value. Bicarb is an alkaline anion that acts as a buffer against acidic hydrogen cations in the body. This relationship is reflected in the equation you see here, which shows the bicarbonate carbon dioxide buffering system in the blood. How these variables interact to determine pH is reflected in the Henderson-Hasselbalch equation, which you may recall from your undergrad chemistry courses. Without going into too much detail, the equation essentially tells us that pH is determined by the combination of bicarbonate and CO2 levels, not by the value of either alone. As CO2 climbs, pH becomes more acidic. As CO2 decreases, pH becomes more alkalotic. As bicarb rises, pH becomes more alkalotic, and as bicarb falls, pH becomes more acidic. It's easy to get lost and confused by all of these numbers, so when interpreting ABGs, it's important to have a systematic approach. The goals of the approach will be to determine what the patient's primary underlying disorder is and whether or not their body is appropriately compensating. There should also be an assessment of whether or not there are additional secondary acid-base disorders occurring. Everybody develops their own method, but what follows is an example of a systematic approach to analyzing ABG results. Step 1 is to assess the pH and decide if there is an acidemia or an alkalemia. A pH less than 7.35 is considered acidemic. A pH greater than 7.45 is considered alkalemic. The patient's primary disorder will determine the pH. The next step is to figure out if the primary process is respiratory or metabolic. In an acidosis, if the CO2 is high, then the primary process is a respiratory acidosis. If the bicarb is low, then it's primarily a metabolic acidosis. In alkalosis, if the CO2 is low, then it's a respiratory alkalosis. If the bicarb is high, it's primarily a metabolic alkalosis. A normal CO2 is about 40 milliliters of mercury. A normal bicarbonate is about 24 millimoles per liter. Next, you should ascertain if the primary process is being appropriately compensated for by the body. We'll start with respiratory disorders. In a respiratory acidosis or alkalosis, the body will act to increase or decrease bicarbonate levels to try to balance out the pH disturbance. For example, in a respiratory acidosis, CO2 levels increase, which causes a decrease in pH and an acidosis. In response, bicarb levels will increase, causing a compensatory metabolic alkalosis to help bring the pH closer to normal. Initially, this is accomplished by the buffering system in the blood. This acute response is relatively modest. In an acute respiratory acidosis, we'll see the bicarb increase by only about 0.1 for every 1 millimeter mercury increase in CO2. As the respiratory acidosis persists, the kidneys act to retain bicarbonate to further compensate for the acidosis. This process takes about 3 to 5 days. So in a chronic process in which the kidneys have had more time to compensate, we should see a 0.4 increase in bicarb for every 1 millimeter mercury increase in CO2. So by assessing the extent of metabolic compensation for your patient's respiratory acidosis, you can develop a sense of whether the process is acute or chronic. The same principle holds true for respiratory alkalosis. In a respiratory alkalosis, CO2 is decreased. The body will try to compensate by lowering the bicarbonate and creating a compensatory metabolic acidosis to try to bring down the pH. In an acute process, bicarb should decrease by 0.2 for every 1 millimeter mercury decrease in CO2. In a chronic process, bicarb should decrease by 0.4 for every 1 millimeter mercury decrease in CO2. If the degree of metabolic compensation does not appear to be appropriate, you have to question if there is a concurrent metabolic acidosis or alkalosis that is limiting the body's ability to appropriately compensate for the respiratory process. If the bicarb seems too low, there could be a concurrent metabolic acidosis. If the bicarb seems too high, there could be a concurrent metabolic alkalosis. This is called a mixed disorder when this happens. If the primary process is not respiratory, but rather metabolic, we take a different initial path. If there is a primary metabolic acidosis, we need to determine if there is an elevated anion gap. The anion gap is determined by subtracting the chloride and bicarbonate levels from the sodium level. This should be about 12 plus or minus 2. There are very specific etiologies for a metabolic acidosis with an elevated anion gap, so finding an elevated anion gap can help you narrow your differential diagnosis. Keep in mind that patients with a low albumin will have a lower anion gap. For every gram of albumin less than 4, the anion gap should decrease by 2.5. So for a patient with an albumin of 2, their anion gap should be about 7. For them, an anion gap of 13 would actually be abnormal. If you detect an anion gap metabolic acidosis, you must ensure that there is not a concurrent metabolic process occurring. This is done by calculating what is called the delta-delta. The delta-delta is determined by taking the calculated anion gap minus the normal anion gap and dividing that by the difference between the normal bicarbonate and the actual bicarbonate. If the result is 1 to 2, then it's a pure anion gap metabolic acidosis. If it is less than 1, there is a simultaneous non-anion gap metabolic acidosis occurring. If it is greater than 2, there is a simultaneous metabolic alkalosis. The final step in assessing a primary metabolic process is determining if there is appropriate respiratory compensation. Unlike metabolic compensation, respiratory compensation happens rather rapidly, within minutes to hours rather than days. In a metabolic acidosis, we use a formula called Winter's formula. The CO2 should equal 1.5 times the bicarb plus 8 plus or minus 2. If CO2 is greater than expected, there is also a respiratory acidosis. If the CO2 is less than expected, then there is also a respiratory alkalosis. In a metabolic alkalosis, the CO2 should equal about 0.6 to 0.75 times the bicarbonate, plus 40. Again, if CO2 is greater than expected, there is also a respiratory acidosis. If it's less than expected, there is a concurrent respiratory alkalosis. In summary, ABGs are extremely helpful in determining a patient's underlying physiologic process. It is necessary to have a systematic approach to interpreting ABGs to ensure accurate diagnosis. The goals of your assessment should be to identify the primary process, assess for appropriate compensation, and identify concurrent disorders. In our next podcast, we'll review some example cases to put this method into practice.